Welcome to the PIL series. I will be telling you how to go through the PILs for your practical purposes in the OSCE stations for MRCOG Part 3 or even in obstetrics and gynae exams, any exams, right? So these RCOG PILs can be of real benefit in understanding if you know how to read it and use it for your purpose of examination. So let's suppose we are starting with the ectopic pregnancy, and this is a simple way they give the PIL. This is basically for the patients, but how we can use it. They give the definition of ectopic pregnancy. We have to apply this in the applied clinical knowledge part, and like we have to start with the patient. During explaining the patient, we just start with simple drawing. Let me draw and explain you what is an ectopic pregnancy. Usually pregnancy is implanted in this uterus, in the cavity of the womb, and it grows here because of the enough space it has. In ectopic pregnancy, the pregnancy is outside the womb, means it is away from its normal position. Mostly it is in the fallopian tubes. These tubes, they carry the egg from the ovary, and here the sperm meets the egg and pregnancy develops here. So if it fails to move down, roll down in the womb, it gets stuck over here. So this is called a tubal ectopic pregnancy. It affects 1 out of the 90 normal pregnancies in UK. And why we are worried about it, that this pregnancy is not a normal pregnancy. So you have to soften your sound according to the news you're giving or according to your explanation. So because the normally located pregnancy has enough space to grow, here when the pregnancy grows, this because of lack of space, it get burst out and internal bleeding starts. It's not able to grow here. So that is why it is not a pregnancy which can grow, and we have to terminate it, right? So other things you can tell her. So this definition is mainly for the explanation purpose. So these are the beautiful diagrams. They have explained like what kind of different pregnancies, but you have to tell that mostly it is in the tube. If you have found that this patient has a tubal ectopic pregnancy, so you can mainly focus on the tubal ectopic. If she asks what can be the other place, that's a different scenario. Then you can tell it can happen in the ovary itself or in the tummy. It can roll back and grow there. So now, what are the other important things which we have to pick up from this PIL? The symptoms. So what about the symptoms of the ectopic pregnancy? So whatever symptoms here given in the PIL, you can use in history points. So you can very well pick it up from the NICE guideline and RCOG guidelines also. But from the PIL, you get yes, they are giving you the summary. So wisely pick up the history points from the patient information leaflets. Like when you are taking the present history of present illness, then you can ask about it. Do you have any pain in your lower tummy? Is there any bleeding or spotting? What's the color? Like, is it darker or lighter? And if she's in the emergency, and you can ask that, if she says, yes, I have pain. So is it radiating anywhere? She'll say yes or no. Then you can specifically ask, is it going like, do you think it increases when you lie down, and is it going towards the shoulder? So that way you can ask about the hemoperitoneum, right? And you can think that this may be a ruptured pregnancy. Do you have any upset tummy or pain during opening of bowel? That's it. So these are the main symptoms you can ask in the history, right? And your station, what you have to pick from here is that you know very well that she has 3 channels, that she can go to GP or midwife, and she can also, she can go to GP, she can go to emergency. You have to tell her that, in the emergency, you can report immediately. And apart from that, the early pregnancy assessment unit, if she is stable, or you have to tell her about the next pregnancy. So you need to know these 3 gateways for the pregnant woman, especially for the overseas candidates who are not practicing in UK. And then from the PIL, like if there is a risk column, so you can do the risk assessment in this pregnancy, right? So risk factors you need to ask you in this pregnancy, that if she has any, because that can help you in further counseling of the patient. Or if you have a suspicious case of ectopic pregnancy, then from the risk factor, you can definitely put them into your high risk suspicion. So is this your first pregnancy? Is it a planned pregnancy? If it's not a planned pregnancy, you can ask, were you using any kind of contraception? Because in the back of your mind, you should know that IUCD and mini pill can increase the chance of ectopic pregnancy. You need not to specifically ask about just ask whether she was using any contraception or not. If yes, then what kind of? She will herself tell, right? Then, was this a spontaneous conception or an IVF, right? Was it a natural pregnancy? She'll tell you yes or no. So you'll get to know whether it is IVF or not. So you need not to try smarter by asking her unnecessarily leading question to IVF. Did you have any infections in the past, like sexually shared infections in the recent past or before that? She'll tell you, because sexually transmitted infection or tubal infection can be a cause for ectopic, a risk factor for ectopic. You can ask about the period of amenorrhea and gynae history. These 3 points are important: STI, LMP, and contraception. In the personal history, you need to check about the smoking because it increases the risk of ectopic. You need to counsel her for future pregnancy, and you have to tell her about the not to smoke because it may increase the chance of having a ectopic again, because you should apply a non-blame approach. Now you have taken the history, you have told her that this is ectopic pregnancy and it can happen this way. In between that, after taking history, you have to tell her that I may need to examine you. If you have ultrasound report, you have beta HCG report, you can tell her about the clinical examination. Whatever is missing, you have to advise that along with the examination. Like, if you allow me, these are the words you have to take care. So with your consent, if you allow me, I want to examine you in the presence of a chaperone. We need to check your tummy. We may need to check you from inside because the pregnancy is at a very early stage if you don't have the diagnosis. If you have the diagnosis, don't offer the internal examination. Then all the tests, depending upon, I have your ultrasound report, we may need to offer you some blood tests, and which include the pregnancy hormone test. And if you find that she is an eligible candidate for methotrexate, you have to tell her we want to offer you complete blood counts, your liver function test we need to check, and a pregnancy hormone check, right? Then explain about the condition, what condition she has, and what are the treatment options for her. So these parts are really for the patients. What I'm skipping, I'm just picking up the points which are beneficial for the OSCE stations. Rest, all you need not to read it completely. You have to read it in a way that you utilize it for yourself, and definitely for a better communication with the patient. So what are the options of treatment? So now when you have told her that this is an ectopic pregnancy, we have to terminate it. We will advise you to get it terminated because it can't grow. It's an abnormal pregnancy, right? So now what you can do is, we have some options for you. Your options will depend upon, and these options depends upon the weeks of pregnancy, your pregnancy hormone level, the ultrasound report. If you want, we can discuss it now. She'll say yes. Then you tell her. In expectant management, you can tell that, we just wait and watch, and sometimes it disappear on itself like a miscarriage. But it is offered only in very early stages and when the pregnancy hormone level is less. So in your situation, if you have the pregnancy hormone and the USG reports, you can advise that in your situation whether it is applicable or not. And also the success rate, if patient asks, you need to tell it is highly variable. We are not sure. We need to keep a active follow-up on you with the pregnancy hormone level test. And 30% to 100%, it is the wide variation. Sometimes it's good, like for 100% it get disappeared, and sometimes it doesn't disappear at all. And then it depends upon this hormone level test. Then coming on to the medical treatment. So you have to tell the patient that this expectant or wait and watch is not for you. So now you have to tell the patient that this medical treatment, whether it is suitable for her or surgical treatment is suitable for her. If you think that both of the treatments can be suitable for her, you have to tell her that there is medical treatment. We give a medicine through injection, and then there is an operation which we can offer you. Do you have any preference, or shall I tell you about the both? Then, if she has been told to talk more about the medical treatment, she'll talk more about that. So you can, it will save your time and your energy. And also, you know that there are two or three options. You can ask her whether she has any thoughts, like if would she prefer medical, would she prefer surgical, or you have to tell her both. Accordingly, she'll tell, okay, tell me about the medicine. Yeah. So there is a drug, we call it methotrexate. It is given in the injection form. It is given in your muscle, right? And usually we give a single injection. And this injection, what it does is it stops the growth of the ectopic pregnancy, and slowly it gets regressed or it disappears, right? So, and one injection is enough. We follow you up with the blood hormone, pregnancy hormone level test, right? If we find that it is very well coming down, we don't need to do any other things. We'll keep on following you until it disappears, right? And if it sometimes it does not, the hormone level does not come down, and you may need another dose, the chances for them are like 15 out of 100 women may require another injection for the satisfactory downfall of the pregnancy hormone, or you can say the pregnancy. And but there is a thing like 7% women, 7 out of 100, may require surgery. This method fails in them, right? Do you have any questions till now? Okay. So this, if she asks about the side effects, you can tell her that with the single dosing or two dosing, generally two doses, it does not have. Otherwise, it's a yes. It is, if given for long term treatment, it do have side effects. That's why it is reserved only for 1 to 2 doses. But the one thing which is to be noted, that for 3 months we advise you not to conceive, because it takes around 2 to 3 months in washing off from the blood. And for the, if you get pregnant again, it can be harmful for the fetus. Yes. Okay. So that's it. You have to tell till here, and then safety netting you have done. Questions you'll ask. She will ask, if she asks you whether can it affect my chance of becoming mom again, you can tell her no, it does not have any effect on the capacity of your ovaries to produce eggs. So it's a safe medicine in that situation. And then surgical treatment, you can tell her that if she doesn't want to go about the medical treatment, before starting for the medical treatment, you need to tell that your pregnancy hormone test, your ultrasound is in a range that you can be offered these two treatment. But if she does not, the pregnancy hormone test is beta HCG is more, and the TVS is showing that there is a viable pregnancy and the size is more, then you have to tell her that we have only this surgical option. You also, in the history point, you need to ask, what are your future plans? If she is gravida 3, 4, or 2, you need to check whether, you want babies in future. She'll say yes or not. And if she says yes, then you have to give the option of salpingotomy also. Then you can tell her that there is a keyhole surgery we can offer you, in which, a tube, the pregnancy will be taken out by a nick we give on the tube, and then we suck out the contents of the pregnancy. But again, we have to follow you up with the pregnancy hormone level frequently, because sometimes some tissue may remain, right? And it may take time to dissolve, or, during the operation, there can be higher bleeding. And for stopping that bleeding, we may need to remove the tube. Frequently ask them, are you with me? Do you have any other questions? Right? Or shall I stop here? Feel free to stop me anytime you feel like you are not understanding anything. Then, apart from that, you need to, like about keyhole surgery, you have to tell that it reduces the stay in the hospital. And though we have open surgery also available for that, but in this, a large cut is given on the tummy. It's like your stay increases in the hospital, and recovery also, like it takes some time, 4 to 6 weeks approximately. So if she asks about that, right? But we offer you open surgery in case of emergency, when the pregnancy get ruptured inside and there is a lot of bleeding, right? And we want to quickly remove the tube and blood from the inside. Then about the salpingectomy, you need to tell, but if you wish for the future pregnancy, it reduces the chance of becoming pregnant to a little. Does not completely reduce the chances. It does not reduce the chances more. So during the operation, if we find that your another tube is not looking healthy or good, and only, or you have only one fallopian tube, so you have to check with her beforehand, right? And then only you can give the option. Don't go by this leaflet that you have to tell these all things to the patient. No, you just have to, in the history only you will get cleared that okay, she has only one tube, then you will give only salpingotomy option. And also in this option you will tell her about the follow-ups whatever she'll be requiring frequently, and also that the chances of having a future ectopic increases from 1 in 90 to 7 to 10 in 100 pregnancies, means 7 to 10% chance increases from more than 1%, right? But the chances of having a normal pregnancy in future are very high, still very high. So we'll advise you to, after the surgery or after the medicine or after the successful completion of the treatment, whatever it is, you have to close the station by telling her that, for the next pregnancy, we will advise you to have an early scan and report yourself directly to the early pregnancy assessment unit, and your early ultrasound scan will be done to check for the location of the pregnancy. And now, what now? Because these type of situation, these situations put a effect on your mental health. So I can put you in touch with a counselor. We do have good counselors, and we do have that option. So shall I put you in touch now? Okay. And I'll, for, if you have any pain, any bleeding or spotting, these are the safety nettings. Pain in abdomen, bleeding, spotting during this treatment, you have to report back if you are prescribing medical treatment. If you are prescribing the surgical treatment, then you tell her that we can plan the surgery. If you allow me, I can, ask my consultant, we can have a word together with your partner, and again, and I can prepare the OT. Whatever situation is, it depends upon which situation you are in. So from this PIL, you have to pick up the safety points. Okay. And that's it. That's how you have to read a PIL, means starting from the beginning. Like you have to pick up the good history points from the PIL. From the sign and symptom paragraph, you can pick up the history points. From the diagnosis, you can pick up the examination and what investigations you're going to offer. And then from the definition in the PIL, you can get to know how you have to explain it in a layman language, in the correct layman language, like what NHS suggests. And then risk factors, you can check in the history points again, and also some of the this thing like risk factors and the safety netting for the patient, right? And then treatment options, yes, you can tell about the all the treatment options. You can pick it up from here. You can cross check, I mean not cross check, you can take few points from the guideline, and you can make short notes about the treatments that you are going to ask, only this much, and tell all the questions which are probable or which can be asked will be given in the PIL itself. So if you have read it carefully, you will be able to answer almost all of them, right? So the complications, the risk of recurrence, the where do they have to report, what are the symptoms on which they should be bothered and they should come and report, come quickly to the emergency, what are the surgical options, how and when it can be offered, when to start the treatment, where to come for the follow-ups, these all things. And also don't forget the importance of contraception. If any pregnancy complication station you like, you are in any early pregnancy or pregnancy complication station, you have to advise them a good contraception before planning of the next pregnancy. And in specifically this condition, you can even add that I'll put you in touch with the contraception clinic, because some of the contraceptions can increase the risk of having the ectopic pregnancy. So they will advise you the safer options, right? So that means she should not take the choose the contraceptions by herself. She need an expert opinion, so that will give you a extra punch. So that's it. See you in the next class.